Hi, everybody, and welcome to this very special edition of the Dr. Keith Darrow podcast. I am honored to have with me today, with all of us today, a true audiology heavyweight, a true pioneer in the field of hearing healthcare, Dr. Douglas Beck. Doug, thank you so much for being here.
My pleasure, Keith. Thank you for the kind invitation.
Oh, absolutely. I just feel like so many people want to hear from Dr. Beck. They want to know his journey to how he's gotten to today, but they also want to know what the future holds, because I think your retirement reminds me of Tom Brady's recent retirement. So, but I think one of the biggest questions on people's minds, maybe just me, is tell us what you really think about Oticon.
I think Oticon is an incredible company. And I had 17 years with him. My job description with him, I had the best job in audiology, right? Sure. My job description was read, write, publish, present, repeat, and every year for 17 years, I published at least 8 or 10 papers with them. I went all over the world on their dime, learning and teaching. And, I want to be unbiased and I want to be objective, but yeah, they make the best products in the world. And, they are so nice and kind and loving. So sure. I behind the pulling back the curtain, it's a phenomenal company, and every single company, I don't care if it's Apple, I don't care if it's Facebook, I don't care if it's Microsoft, sometimes they're going to fall down. Sometimes you got a patient, you really need it. Well, shipping has changed, supply chain has changed. Sure. And so they're all dealing with this. It's not, you can't just pick up the phone and you can't just go buy a car anymore. So we're in a bit of a dilemma, but it'll get straightened out. And so hats off to Oticon. And I had the best bosses. I only worked for 2 people in 17 years, Pierre Lortz, and it was the president for the first 12 years I was there. And then the last 5 years, Gary Rosenblum. And I love those guys. I mean, they've never been anything but generous and kind. And, it's not a company where they tell you what to do. They don't. They say, here's what we've got. Here's what, the needs of the patients are. What do you think? How do we go about doing this? And sometimes we scuttle projects if we don't think it's very good. And sometimes, most often, obviously, we bring stuff forward because it's totally cool. And I have to stop saying we because I'm not part of it anymore.
I was going to call you on that, your use of that pronoun. But I think that's the point. And I did not pre-ask you that. I wanted to know, but I really did believe that was going to be your answer, because I know from even my limited interactions with them, with my time with Gary, with BDG, with many of the people there, it really is a great company. Like every company, they stumble, but the product, that has always been my go-to, regardless of what happens when I pick up the phone, regardless of what happens with shipping. They've always had a phenomenal product.
The professionals and the consumers see that. I mean, they just published a study this last year that, they compared their premium product, which is, the More One with the deep neural network, to the 2 biggest competitors. And we all know who they are. And 80% of all people chose for quality the Oticon More product. So, it speaks for itself. And you look at Hearing Tracker, and I'm pretty sure 16 out of 18 of the last Hearing Tracker recorders, highest quality.
Sure.
So yeah, there's something there. It's a little bit different.
There's definitely something there. And without this completely turning into an Oticon infomercial.
Yeah, Gary would get real upset if that happened.
Oh, I'm sure. Because we could go on and on, but I guess let's backtrack, right? We sort of skip to the end. But how did you end up here? How did you even end up working for Oticon? Because if we're really honest with each other, and I think every student, even currently enrolled in an audiology program, says, I would never work for a manufacturer, right? That's something that either they say or they think. Yeah, but it's not necessarily the case, especially for you. So how did you even get there? I mean, go back to the beginning.
Yeah, dumb luck. Right place, right time. When I got out of the Air Force and I went to school and I had no idea what I wanted to do. I was thinking pre-med, right? And so I went to University of Buffalo, which is part of the State University of New York. I was so incredibly lucky. You know who was there when I was there? Jack Katz. And so,
Okay.
yeah, dumb luck. I honestly didn't know who Jack was. And
I was going to say Dick Salvi, because I think he's always been there.
Yeah, he's always been there. And also, Derek Sanders was there, who wrote all the early oral rehab books. And we had Tom White, who was probably the finest clinician I'd ever known. And so they had this brain trust of audiology that was outstanding. And Jack is still alive. Jack is in his 80s now. And, he introduced me to audiology, and I fell in love with it. And my education there was very different than what you get now, because we were dissecting human brains. And that got me very interested in cochlear implants and intraoperative cranial nerve monitoring. By the time I left with my master's, I'd already been in surgery a few times with Dr. Erwin Ginsberg, local otologist who was doing cochlear implants prior to the FDA approval, part of the trial process. Anyway, long story short, about 83 or 84, I get an invitation to join the House Ear Institute in Los Angeles. This is 3 years before cochlear implants are FDA approved. I jumped on that opportunity. Went out there, spent quite a few years, I guess about 4. And I monitored over 1,000 acoustic neuromas in my 4 years. And acoustics in the hands of Bill House, Ralph Nelson, Jim Benecke, Bill Hitzelberger, Tony De La Cruz, Darrow Brackman. These are the best of the best. Yeah. Acoustic neuromas were 3.5 hours. I mean, skin to skin. We would start about 7 in the morning. We'd probably do 2 or 3 a day. I do 1 or 2 with Dr. Bill House, and I'd be doing 1 in the afternoon with Darrow Brackman. We might be there till 10 at night, something like that on some nights. But now, and these guys with you have to understand that Bill House is the guy who invented the translabyrinthine approach to skull-based surgery.
Right.
So in his hands, it was rare. I'm going to guess, but fewer than 1 or 2%. Translabyrinthine craniotomy for an acoustic neuroma in the cerebellopontine angle or the internal auditory canal. These people would come out 98% of the time normal facial motion. So that, and we're talking 40 years ago. Back then, every acoustic we would operate on. Now that's not true. Now we're at the point where most acoustics are watch and wait, because usually by the time they're discovered, they've stopped growing. That's a very interesting thing to know. Also, we know now that we have all these radiologic procedures where we can stop the growth of the tumor.
Sure.
So if you're
just stereotaxically knife it.
Absolutely. Stereotactic radiosurgery has been out there now for about 30, 35 years, and it's really become quite good, quite reliable. If I were 28 years old and I had a honkin' cerebellopontine angle tumor, let's say a large one, like 2.5, 3 centimeters, I'd probably want it out, to be honest with you.
Sure.
But if I'm 65 years old with that same tumor, they're benign. Generally, they're benign. They're not always benign. They can turn malignant, but it's rare that it happens. And so at age 65, 75, I'd probably be in favor of, watch and wait. So, but everything depends on everything. So we know now that a lot more than we did 40 years ago when I was involved with that stuff. And so, the protocols have changed. And for anybody interested in intraoperative cranial nerve monitoring, the Handbook of Intraoperative Monitoring, which I wrote over 20 years ago, is free. It's at Douglas.
Right on your website.
Yeah, and you can download it for free. The technology has changed, but the anatomy and physiology clearly is exactly the same.
Yes, we haven't evolved that much in the last 20 years.
Not in 40 years. So go ahead.
No, it's what the more, right? You and I recently met in person. I've been following you for years, but the more I get to know you, the more I feel this kindred twinship with you, because I didn't know what I wanted to do. I was introduced to audiology. Next thing you know, I started dissecting brains. Next thing you know, finished audiology school, then went and worked with Dr. Daniel Lee at Mass Eye and Ear, where we were doing auditory brainstem implants, and I was in the operating room with him. And that's really what just drove my sort of passion for really further understanding those ear to brain connections, and how, not just the signal that goes from the ear to the brain. What all my research has been on is that feedback coming back down. That downward processing, whether it be through the efferent system, whether it be through the thalamocortical back and forth relationship. It's fantastic.
It is. So a few things that you mentioned, I want to get back to the thalamus in a minute, but when we think about cochlear implants, it's so important for people to know this is not new. We've been first cochlear implants in the history of the world, 1959, right? And Bill House did 3 of them in 1961 in Los Angeles. And then it took 25 years for the FDA to approve it for adults, and then in 1990 for kids. So this isn't a new thing at all. And further, when you mentioned brainstem implants, first ones done ever in the world, 1987, Bill House did that too. And the guy who designed that electrode is still around. His name is Franco Portillo. Yep. Franco is a very dear friend of mine. I love Franco. He's an electrical engineer. He designed that electrode that Dr. Bill Hitzelberger put directly on the brainstem. And I had a lunch with Bill House and Bill Hitzelberger a few years later. And I said, how'd you guys ever get that by the IRB? I mean, holy smokes, putting electrical right on the brainstem of a human being. And
right, so by the vestibular nerve, right by the facial nerve, right by I mean, brainstem, we're talking about modulating life activities like breathing and all that.
And cardiac, And so I said to Bill House, it's just the 3 of us. We're having lunch or dinner, whatever it was. I said, so how did you get that by the IRB? And he looks up and he goes, I thought Hitzy did that. So there was no IRB. When we did that one, we forgot, and it was the same with cochlear implants. When Bill House started doing cochlear implants, the nursing staff, true story, you can read any of his autobiographies because there's like 3 or 4 of them out there. They used to hide the surgical tools because they say, we don't want this ENT. This guy's an ear doctor. He does not work on brains, and they would hide his instruments. And anyway, so this becomes very important, what you said about top down, bottom up processing and how that works, because, we all think in terms of audiology. We think about hearing, which is perceiving sound, and listening, which is making sense of sound or comprehending sound. But right now, everybody watching, if they're watching you at this moment or they're watching me, right, the occipital lobe, the vestibular the visual cortex is being stimulated. So is the auditory cortex, and they're taking in, the all of this information and making sense of it. And so my point is that the entire brain is actually involved in understanding speech and noise and conversational speech. When we test it on the periphery and we do all these threshold tests, air-bone speech, SRTs, word recognition, not a threshold test, but also not a very useful test for many reasons. We're not really getting the full complement of how does the patient get on in the real world, because all of your sensory input, your taste, your smell, your vision, your audition, all goes through the thalamus. And this is where the magic happens, where everything is coordinated, synchronized. And so if that synchronization doesn't occur, you can't understand what's going on. You may hear it, but you may not make sense of it. So I agree exactly that this upward and downward path is very.
Well, I think it was it Killian Meade, right, who talked about being able to hear something versus all the potholes or all the holes in the system where pieces of sound drop out. And I mean, I've done the experiments where I've literally injected tracer into the ear. Good. And then waited and watched. And what are we taught in audiology school? That the nerves go from, the ear into the brainstem, makes a couple of stops, and then gets to the auditory cortex. Right. And then it's like we forget how much happens after that and how much branches off before it. I use the word invade. The auditory system invades the entire cortex from vision to hearing to feeling to seeing to balance. I mean, thinking, emotion, right? So I think that's also why, and I don't want to go down that path, but I think that's why it makes sense that as hearing goes, so too may cognitive function.
Yeah, this is a new area for many of us. I mean, I've been writing on cognition now since 2009. Mm-hmm. First paper I wrote on this topic was with Jackie Clark. She's a professor at University of Texas, and she's a former president of the American Academy of Audiology. We wrote a paper called Audition Matters More as Cognition Declines, and Cognition Matters More as Audition Declines. So first of all, we got the title, we got an award for the longest title that year. So that was good. But everything that you just said is when you look at the amount of papers in cognition in 2009, when we first started publishing on that, there were probably about 10 or 25 peer-reviewed papers. And if you look at it now in 2022, put in, go to PubMed or Google Scholar and put in cognition, audition, there's probably over 1,000 being published per year. So our knowledge in this area is exploding logarithmically. And this is one of the things that I really appreciate about our professional societies and how important they are. It was very clear in 2018. ASHA says right in their scope of practice statement that this cognitive screenings are an important part of patient-centered care and truly taking care of your patients in a way that allows the patient to have the highest quality of life and the best outcome. So it's not even ambiguous. I mean, it says right there, cognitive screenings.
And it's 2018. That was actually 2018. It was either 17 or 18, but that was when I first got CogniView in my practice. Right?
Oh, right.
They were looking in other fields. I came across a flyer and I said, we need to do this. It's in these standards. It's something that we really need to take serious. But look, fast forward to 2022, you and I both know there's still a lot of people in our industry who are saying this is outside our scope of practice. And I would love your thoughts on that.
Yeah, well, people outside of our scope of practice. Yeah, I know. So let's go back again one more time to the early 80s when I was a young kid with hair in the operating room. When we were doing cochlear implants back then, we knew very well that vision and audition had to work together in synchrony and synergistically for the patient who was deaf at that time. We didn't implant people with moderate or severe hearing loss at that time, only 110 dB thresholds and worse. So we knew very well that for them to do well with the cochlear implant, they had to be able to have vision and audition working. So one of the screeners, we used to do something called the MAC, which is minimal auditory capabilities, came out of UCSF. Dorcas, Kessler, and I forget who else. But we, on the front line, I used to screen vision all the time because when we had candidates for cochlear implants, we would say, test one is a visual screening. Doug's going to do that. And then if they didn't have normal or normally corrected vision, we insisted they see an optometrist before we go further, right? And then every one of them got a complete psychological evaluation. And I think it was Dr. Wexler himself who was on our team. And this became very important that our scope of practice. And then, after when I wasn't doing that, I was in the operating room. And people were saying, well, that's, in fact, with all due respect, I love Jim Jerger, but Jim was kind of opposed to us being in the operating room and doing vestibular work and stuff like that. And so it's evolved. So scope of practice, we're not trying to enlarge it. We're just, I'm trying to say we should practice fully to our scope of practice. Because here's the thing, Keith, and you and I talked about this earlier, but in the USA, you have 335 million people. And of those, about 38 million have hearing loss on an audiogram. But this is very important for everybody to know. You have another 26 million people in the USA, no hearing loss whatsoever, none, zero, thresholds between 0 and 25. However, 26 million have ADD, ADHD, dyslexia, auditory processing disorder, auditory neuropathy spectrum disorder, mild cognitive impairment, traumatic brain injury, maybe Meniere's disease, maybe early Alzheimer's, maybe a million things. And these people will come in and their number one complaint is, I can hear, but I can't understand.
Can't understand.
Right. And this is not new. I mean, so if we are just screening hearing, airborne speech, we're going to miss 26 million Americans, number one. Number two, you go back to 1949, Dr. Michael Buss published in JSHR, which is an ASHA publication. And he said, here's the funny thing, cognition, psychology, auditory processing, it's all kind of the same. It's just a matter of which lens you're looking at it through. So, you're a neuroscientist, you're an audiologist, so you're looking at it kind of the way I am. But if you take that exact same patient and you give that patient to a speech language pathologist, they're going to do their stuff. And they may say, well, the child has specific language disorder. You give that child to a pediatrician, exact same kid, and the pediatrician may say, well, I think he has ADD or ADHD. Let's try him on Ritalin or whatever the trendy drug of the day is. And that's not a problem. That's just an acceptance that we all have a different orientation in education. When you go through medical school, you learn about this as a medical or a surgical problem, not a surgical problem for this. But when you go to audiology, you get your doctorate in audiology, you look at it through a lens that includes the peripheral auditory nervous system, the central auditory nervous system. But now, it's not just Broca's and Wernicke's. We know, as you said earlier, the emotional impact of what you're listening to is huge, and it colors what your brain perceives. So we have, the frontal lobes involved, and we have the parietal lobes because we're working with vision as well. We have the superior temporal lobes, which includes Heschel's gyrus and Brodmann area 41 and 42, and we have the occipital lobe. And anytime, particularly in a challenging acoustic listening situation, that entire brain is involved trying to decode what that information actually means.
Well, there really are these tangible neurologic connections that are being disrupted. So we think, right? If we stay at the surface level, and we don't dive a mile deeper on the surface level, it's okay, well, patient has hearing loss. Maybe they will socially isolate themselves. Maybe there'll be some depression because they're not with other people. All that may be true, but it may also be the case that there really is a breakdown in the brain between the emotional centers in the limbic system and the auditory system. So there's actually something neurological going on. It's not just, oh, they don't want to be with other people. There's really much more to this.
And we're only at the beginning of this, seriously. I mean, what we know today, the half-life of this knowledge is probably 4 or 5 years at the most. It's going to change dramatically. And I know you're familiar with this. In 2020, The Lancet, which is the world's premier medical journal, came out and they said your primary risk for dementia, right? For 60% of your risk is DNA, deoxyribonucleic acid. So what that means, you can't change that. However, 40% of your risk for dementia is based on 12 modifiable risk factors. And the most significant of all of them is, of course, hearing. Hearing has an 8.2% PAF, which is population attributable factor. So if you are on a course where things aren't making sense and it may or may not be audiologic, I think it makes total sense, as you said earlier, is you might use the Cognitive Thrive, which is a screening test, because you want to know that this patient essentially passes or fails a cognitive screening. If they pass, great. That's an audiology problem. It's an audiology patient, and you proceed. If they fail that 5-minute screening, then you're still going to do what you're going to do. But the important thing now, you're going to refer. The same as if they had narrow bone gap, the same as if they had Bell's palsy, the same as if they had, a perf in their tympanic membrane, the same as if they had sudden sensory neural loss. I mean, our goal is not, supposing you saw a patient with a right eye that was oozing and bloody. I mean, I'm sorry to be gross, but if that's the case, you're going to refer. You're going to say, listen, I noticed that, your right eye looks really problematic. I'd like you to see, why don't you see the ENT? He's here today, and let's get you referred over to an ophthalmologist or whoever, but we do this all the time. We refer or we don't. And that is a big part of audiology, right? Is we're always looking for these red flags, at which point, even asymmetric tinnitus, you're going to get an MRI, asymmetric hearing loss.
But I think we're just so ingrained in the traditional red flags. And yet we've always wanted a seat at the table, right? The table with the big boys. That's part of the reason we're the AUD. I mean, there's so much to that conversation. Doing our job and referring when appropriate with a cognitive screening, I think just gets us closer to being at that table. And there's all these discussions about how do we get more respect? How do we get more referrals? How do we work closer with MDs? It's right here in front of you. If the MD only sees airborne gaps that you send them, well, then that's all they're going to think you do.
Right. And this is such an important growth factor for audiology moving forward. Because number one, it's already in our ASHA scope of practice, very clearly stated 2018. Number two, the executive director of ASHA was Dr. Arlene Petranton, dear friend of mine. I've known Arlene for at least 20 years. But when she announced her retirement, I did an interview with her at hearingreview.com. And Arlene, as executive director of ASHA for 17 years, said, cognitive screenings by speech language pathologists and audiologists, that is patient-centered care. That is quality of life. That is what we're supposed to be doing. So I don't think there's really any big fusses over is the scope of practice, because we're not diagnosing, we are screening, and we're not telling anybody they have cognitive decline. You can't do that based on the screening, and that would be totally
inappropriate.
Right. And there's no charge for it. But what it does is it allows us to better understand who that patient is, so we can make a better referral, so the patient's eventual outcome will be stronger, better, and quicker. Now, if you do all that, and people say this all the time, Keith, they probably say it to you too, what's the point of doing a cognitive screening? Because, you can't change it. That's not so true. There is new evidence that people who have lesser speech and noise ability are more likely to have cognitive decline more rapidly. There's new evidence that shows that, you can do speech language training. I mean, this is what speech language pathologists do. They work to train and rehabilitate language skills. It's one of the things they do. They do many things. There are memory clinics popping up all over the USA. There are, brain training tools. I don't want to mention any because it'll sound like I'm endorsing them. And I want to also say that when you said cognitive screenings. So there's quite a few. Some people are doing MoCA already, which is the Montreal Cognitive Assessment. Some are doing the mini mental state exam. Some are doing mini cog. Some are doing the Cognitive View Thrive. The reason that I think the Cognitive View Thrive is so cool, and I want your thoughts on this because you are the auditory neuroscientist in the room. But when I do a MoCA, right, I have to read the questions to the patient, and the patient responds, and then I write down the response. But they're interpreting what I'm saying. I'm interpreting what they're saying. So you have this tester and testee bias going on.
Well, subjective versus objective.
Yeah, and this is the point.
To me, right? It really boils down, it's pretty black and white.
It is. And if you're using an automatic digitized system like Cognitive View Thrive, then there's no tester bias because the patient's doing it themselves. And they don't have to read. Do they have to read? I mean, they get very, very simple instructions.
Very simple.
I've never seen a patient who couldn't do it. And I think this is the future because we want to take the subjective nature out of it. It's almost, if we're doing these things subjectively, you have to wonder, well, what's the point? It's like doing word recognition score with monitored live voice. If you're doing it MLB.
Wow. Please tell me that doesn't still happen.
Oh, I think it's.
I'm kidding. I know it does happen.
Yeah, I think it's probably 70% of all tests. And, Lisa Lux Mendel wrote a paper on this years and years ago. And she said, if you're trying to save time, monitored live voice is definitely not the way to do that because all you've got is a VU meter telling you, right, I hit the loudness RMS, root mean squared. You didn't, your whole spectral envelope wasn't equally loud. And then, of course, you have timing characteristics. You have the fact that you have an accent, I have an accent, the patient listening has an accent. You've got the room noise because it's monitored live voice. You've got all that bad stuff going on. And Lisa was very clear, that if you want to save time, just do the prioritized lists that have the most difficult words first. You give them those 10. If they get all 10 right, you can write 100%.
Why are we always trying to save time? Seriously, I really don't know, because I want your take because we share this value and I certainly don't know the answer. Why are we constantly trying to save time? And so to save time, we do monitored live voice. To save time, we don't do speech and noise testing. To save time, we don't do real ear. Do you know the answer?
I think we've evolved, over these years to focus on, being a support service for ENT, which I love ENT. Some of my best friends in life are neurotologists, but I think that's wrong. And I think that let me start at the beginning on this. There is no other profession that says free screening. I mean, think about this. Does your neurosurgeon do free screening? Does your dentist do
I'm not going to that neurosurgeon.
Yeah. Or you're going to go to that internal medicine doctor who says, Keith, come on in. We're going to do a free evaluation. Nope. Because we all know this is the sign of a bad practitioner or somebody who is trying to put it all in the front end and they're going to make it up on the back. It's not professional. And I always worry when I see free screening. I would vastly prefer for us to say, do you have difficulty with speech and noise? Do you have tinnitus? Do you have problems understanding words in difficult listening situations? And get rid of the word free. Charge for your time. We are professionals. There's no other, and we feel guilty that we're charged for a hearing test. And maybe you should if your complete hearing test is $255 and a $1K.
You just hit the nail on the head. If you're not doing everything, maybe you should feel guilty.
Right, because this is the thing. Well, go back to the numbers I shared with you earlier, and those are peer-reviewed. Jeff Danhauer and I published them 2019 or 2020. 2020 in Journal of Otolaryngology, ENT Research. And the thing is, we're missing half the people who come in with complaints if we're not doing best practices. And so, in a busy ENT practice, you don't have time. I get that. So you do the clinical diagnostic work, ENT, move on. But every one of those patients who complained about speech and noise, we should be saying, listen, it's like an HAE eval. We set that up for an hour. It's like an ABR. We set that up for an hour. It's like an ECOG. We set that up for an hour. It's like, we have lots of appointments that we set up for an hour. But what we don't set up for an hour is a comprehensive audiometric evaluation or a comprehensive hearing aid evaluation. And at that time, when you have that hour set aside, charge them. I don't care if there's a CPT code. I don't care. And I don't care if you make $5 or $5,000. I don't care. It's none of my business. My point is that our job, right, is to take that patient with normal thresholds who came in complaining about speech and noise. We should be doing a speech and noise test. I wrote one with Dr. Lauren Benitez AAA published it 3 years ago, and it takes less than 2 minutes, and it's free. We don't try. Oticon didn't make any money. I don't make any money. Lauren didn't. It's free, and you already have the tools. Anyway, so you're supposed to do a speech and noise test. You're supposed to do a listening and communication assessment. Which could be HHIE, HHIA, the COSI, the International Outcomes Inventory. Do something, because that's what tells you who needs help and where they need it. Airborne and speech doesn't tell you that. The reason that we put so much emphasis on airborne and speech is because it matches up with otolaryngologic diagnosis right? So I can look at an audiogram and I can say Carhart notch, probably oto. I can see an asymmetry, could be Meniere's, could be an lymphatic hydrops, could be, retrocochlear, but further testing is needed. I can see presbycusis, I can see a noise induced. So very important to do that. I'm not minimizing that, but think about this. Nobody ever said that's the stopping point. That's the entry level basic stuff to know what you're talking about. But then we have to take it further because we have a patient there. And if we don't, you can't find what you don't see. If we don't investigate the patient's complaints and status quo, nobody else is going to. This is our profession. This is our profession. And if we don't, what's going to happen?
Dare I say, there's going to be over-the-counter hearing aids that do self-testing at home. You can test your hearing. There's so much more that we need to be doing, right? I say to my intro to audiology students at the undergrad level, if your patient walks into the clinic saying, I have a hearing loss, and walks out an hour or 2 hours later and says, yeah, I have a hearing loss, you've done nothing. You have literally done nothing for that patient. Why do we stop at the word diagnosis and not include differential diagnosis? I'm teaching in my intro class how to separate the sensory from the neural, but it just seems like every patient we deal with still just walks out of the practice with sensory neural.
Yeah. So when that term hit, that's when things start to go bad, I think. So for those who are not familiar, Harold Shukneck back in Chicago was a incredible ENT doctor. Yes. And he used to separate this out. It wasn't sensory neural hearing loss. It was sensory, which would be outer hair cell, inner hair cell, maybe up to the synapse. And then you had neural, which could be auditory neuropathy spectrum disorder, auditory processing disorders, central disorders, things like that. And when we started to term them all as sensory neural hearing loss, we lost something. We stopped looking deeper to see what really was up. So we got by with that for a long time because the last 30 years, 40 years, we had a lot of people go into private practice. Hearing aids could pay the bills and all that. But now with OTC, I think it's going to be a bit of a mess because, first of all, I think the FDA has screwed this up almost beyond recognition. This is so important that all of the major groups in the US, so you had AAA, ASHA, the ADA, HLAA, you had HIA, you had IHS, you had all the major hearing groups saying 25 dB of gain, 110 dB of output. And then you had the FDA drop their stuff in 2021 in the fall, and the comment period ended in the middle of January, saying, oh, no limit on gain. So you're going to have people absolutely who have listening disorders, those 26 million, they're going to go try something at Walmart or CVS, and they're going to stick it on their ear, crank it up about 35 dB, right? They're going to say, wow, this is great. I solved it myself. Yeah, right up until you get that noise-induced hearing loss or that acoustic trauma, because there's no limit on the gain. Yeah. It's a mess. The first time I saw an advertisement for the new power over-the-counter hearing aids, all I could do, literally just shake my head. Really. Yeah, it's shocking. And the thing is, as I mentioned, all of those groups, we were all in favor of OTC. We didn't say, oh, you can't do this. Oh my gosh, it's the end of the... No, actually, we wrote documents supporting it and saying how to do it so it would be done safely. And I was a consultant unpaid for the Hearing Industry Association. So I hate to think of the names because I'm going to forget a bunch. But back in early 2016, 2017, when this first reared its head, right, and President Trump wanted, to have OTC, and he signed it on the back of that pharmacy bill. And a lot of people think, oh, this was bipartisan. No, it was Grassley and Warren. It was bipartisan. You cannot blame Republicans or Democrats for this nonsense. Right. It was Warren and Grassley pushing it forward. And so the funny thing about it is back then, Brent Edwards, Dave Fabry, me, Tom Powers, Harvey Abrams. If I'm leaving anybody out, I love you and I'm so sorry. But I think it was the five of us. We wrote a 20-page document with 400 references And the Hearing Industry Association sent that to the FTC and to the FDA, and they said, look, you can do this. Here's how to do it. You got to do it safely. You got to worry about hearing loss and long-term. You got to worry about, can people physically get these things in their ears? You got to worry about warranty. You got to worry about loss, theft, and damage, because there's a lot of claims on that. You got to make sure that somebody's taking care of the patients over the long term. This is really, really important stuff. But if you want to do it, we could do it. Here are some guidelines. And then a year or two after that, the consensus statement of all those national groups came out. And yet the FDA apparently didn't read any of them. I couldn't be more disappointed in the FDA. Personally, not representing anybody except my own.
No, I understand that. And I think at the end of the day, right, and I'm not one of these conspiracy theorists, but at the end of the day, science, I think, will always take a backseat to corporate America and all that money. And I mean, it look, it is what it is. And you're right, it was a bipartisan effort. There were good intentions, but like everything, I don't know, maybe just too many people took their eye off the ball, and now it's the wild, wild west.
Yeah, I'm a little concerned. I mean, it will sort itself out. You've already seen a lot of these companies that were headed towards OTC, go belly up. I think Bose is out of it now, and this is only April of 22. And Bose was, they had their de novo, and they got and I thought it was a reasonable product at that price point.
Right.
But apparently they're on stall, or I don't know their status, but I don't think they're active right now in that marketplace. SoundTalk went out. I thought that was a reasonably good product. Doppler's already gone out, so it's not as easy as it seems, just a one size fits all sort of a hearing aid thing. And
it's not. I mean, you could understand the mind of an investor. Hey, there's 42 million people. This seems pretty easy, right? This looks like low hanging fruit, but from people like us, and you've been around a little bit longer, it ain't that easy.
It ain't that
because
easy.
The health literacy when it comes to hearing loss is just abysmal.
Deplorable. I wrote a paper about 8 or 10 years ago with Curtis Alcock, and it was called "Right Product, Wrong Message." And it's so interesting. It was about hearing aids. And the thing to me that's so interesting is about 4 out of 5 people with hearing loss are never going to seek help. And the reason they're never going to seek help is they don't perceive a problem. You could have a precipitous sensorineural high frequency loss, go through your whole life and not know that. You could have a mild high frequency loss and not know that. And when do people seek help? And I think this gets back to best practices. People seek help. What seems to separate them is when they're having difficulty understanding speech, which may or may not be a hearing problem. It could be a listening problem. Again, hearing is perceiving sound, listening is making sense of sound. So if you can't understand speech and noise, you might seek help. And the 1 out of 4 or 1 out of 5 people who seek help probably do not do well on a speech and noise test. And the reason we don't know that is that 80% of audiologists don't do speech and noise tests. And you mentioned Meet Killian before. I just, so people know, he's great. I just had dinner with him about 3 nights ago at the AAA in Chicago. Well, we didn't have dinner, we had drinks, but he's still telling stories, and he's still a genius.
Well, that's awesome. I did not realize that he was still sort of active. So that is pretty cool.
Yeah.
So let me ask you, we got a few minutes left here. I think what a lot of people want to know, and I think we've teased them long enough, is really what is next for Dr. Beck, right? I mean, I looked you up on LinkedIn. I mean, we've been connected for a while now, but I see that your new title has been changed to Simple Country Audiologist.
Yeah,
I don't think anybody's buying it, Doug. So,
well, since we announced my retirement a long time ago, almost 5 months. Well, I told Gary, the president of Oticon, I was going to retire in November. And it was originally going to be December 31st, then it became January, then February. And I think Gary released it to the public in December. And I had a lot of really amazing consultation things come my way, things that I wasn't really involved with or even considering. And I certainly will not work for another hearing aid company, even though 2 of them have approached me. I won't. I mean, Oticon was the best, and I'm happy to leave my hearing aid legacy there. But there are other opportunities in neuroscience and in consulting that are just a joy. And to be honest, I've still got probably 8 or 10 more lectures I'm doing for Oticon over the course of this year. And I'm consulting back to them as a private consultant for some of those lectures. Sure. And, it's just really, I have a lot of hobbies. I am way too busy, and I love being really busy. I'm into martial arts for almost 40 years now. I work out.
Play the guitar.
I play guitar.
I've been listening to some of your music on, what is it, DrDougBeck.com?
Yeah, DouglasLBeck.com.
Okay.
And so I'm trying to learn Spanish, which is funny because I was born in Santiago, Chile, but my Spanish is deplorable. I know about 14 words. So if there's an emergency and somebody has to count to 10 in Spanish, I got that.
You're good.
If we're ordering in a restaurant, not so good. Yeah. So I have a lot of things that I like to do and that I want to do. And so it's just, stay active. It's good for your brain. And you mentioned this in passing earlier, that one of the things that the Lancet report said, social isolation is very bad for your brain. And we all knew this. We knew this since the 1999 National Council of Aging study. But people have to take that seriously. The worst thing you can do is sit around, drink beer, and watch football. Now, that's not to say there's not.
You can do that on a Sunday afternoon for a few hours.
Absolutely. And if you do that,
all right, because you got me worried there.
And I'll even bring the beer. But the point is, we need to keep our brains engaged throughout life. And that whole thing about being an adult lifelong learner, turns out that's the best thing for your brain.
So what is your passion right now moving forward? If you can choose, right? You're no longer tied to anything. You can choose. What is your passion? What do you think your goal will be over the next 5 to 10 years?
I want to play more in the neuroscience sandbox. I think coming in with 40 years of audiology, that there's a lot of good synergies there. Mm-hmm. And I don't make albums anymore because the music industry has changed. But if you look up the Jeff Keith band, I'd like to do a reunion tour with them. We kicked ass for a number of years.
That sounds awesome. So what do you think? What does audiology need to do in the next, again, I'll go to 5 to 10 years? So what I've been preaching out for a while is we're at an inflection point, right? So audiology has built up itself for the last, 30, 40, 50 years. We kind of plateaued off. And I think that plateau over the past decade or two is what forced over-the-counter hearing aids to come into play. So now we're either going up or we're going down. What's your prediction and how do we get there?
First, I want to agree with you. I think the reason that we have OTC, and I say that as somebody who went to the majority of the FDA and FTC, was because we taught the world hearing screenings are free, and we taught them that audiology is press the button when you hear the beep. Those are both surface scratchers. They are nowhere representative of what it is that we do and what we know. And so, I think in many respects, we shot ourselves in the foot with that nonsense. We should have been doing scope of practice diagnostics and rehab the whole time. Where do we need to go in the short term and over the next 5 or 10 years? Well, I think number one, we talked about cognitive screenings. I think that has to be a part of every adult evaluation, over age 50, 55, something like that, because so many patients complain about speech and noise, but you don't find any audiometric problem with them unless you're doing communication and listening, speech and noise, et cetera. So I think that's got to be part of it. I think pharmacology. A lot of us have taken courses in pharmacology. A lot of us have taught courses in pharmacology. We are one of the few healthcare doctoring professions that can't prescribe. When you think about, optometry, they can prescribe, ophthalmic antibiotics and similar drugs. When you think about chiropractors, they can order x-rays and things like that. Podiatrists can. We are one of the few that can. And I think it's important for us to come into our own. And people say, oh, well, there's too many antibiotic superbugs and too many antibiotics out there now. Well, that's an important point. But who was it who ordered all of those? Yeah, exactly. It wasn't the audiologist. It was the MDs. So, and I love MDs. I'm not trying to be negative.
Of course. No, I get it.
But my point is, listen, when I see a kid with otitis, isn't it silly that I have to send him to the pediatrician who's going to send him to the otolaryngologist who's going to give him a course of antibiotics for 10 days and then back to me for testing. And then we just so grossly increase the cost of taking care of that child. And when you think about the military model, you go in to see the audiologist can diagnose you. And if they could just write that 10-day script, if it's otitis, if it's not otitis, obvious, because, antibiotics only work when we have bacterial infections and they don't do anything for viral infections. We all know that. That's not like, wow, doctor, that's shocking.
I mean, you don't need an MD for that.
Yeah. And nurse practitioners, I love nurse practitioners, and my sister's been a nurse for over 55 years. And when I was in surgery, when I was at the House Hair Institute in Los Angeles, and when I was spent my 1 year at Loyola doing nothing but back surgeries, half the anesthesiologists were nurse anesthetists. So they're brilliant. But you and I have a lot more education than they do. And so not to degrade what they do. I love them. And I was so honored to work with them. But but why is it that they can tell a patient, oh, yeah, that infection needs attention. Let's try this for 10 days. And if it doesn't clear up, we're going to send you to somebody else. Maybe we're going to do it in parallel. We're going to start you on antibiotics right away because it looks like, and maybe we should order, I don't know, a CBC and actually know what the heck we're doing, just like a physician would. Because, we do this in audiology. We skip all of these steps that are so important. We don't do complete scope of practice. So we try to do free screenings. I don't really think that free screenings have ever worked out well. I don't know if you're familiar with Larry Medwetsky. Larry runs a Gallaudet clinical audiology program, and he was at NTID, National Technical Institute for the Deaf in Rochester. And Larry did this amazing project where he followed 1,800 people who were screened, followed them for a couple of years, all the clinics within 100, 150 miles, right? And he got buy-in from all these people. This is about 15 years ago. And he found out you screen 1,800 people, only about 300 of them are going to do anything. And of those who do something, probably fewer than 50 of them wind up with hearing aids. And it's the same thing that we found out in the VA, right? Mike Valente and Amin Amlani wrote this brilliant study on, is cost really the issue? This came out in Otolaryngology Head and Neck Surgery in 2017. Found out it wasn't. What we learned then is that the US has the most expensive hearing aids in the world, but we also had the most customer satisfaction, right? The highest ratings from our patients. But so more specifically, what they found is that when you have places across Europe that are free, like even New Zealand and Australia, but Canada, all of Western EU, hearing aids are basically, you get that as part of the national health. So their rate of use is about 0.32, 0.33. Our rate, I said that backwards. Their rate of use is about 0.41, 42, 43.
Yeah, so it's up in the full, right? They're up in the 40% adoption.
Right. And ours is about 31, 32. But we're the most expensive place in the place.
So maybe, right? And I've been trying to explain this to people. So maybe 10% of people genuinely can't afford it.
Maybe less. Amin Amlani said, and I love Amin, he's a genius, and he put in there that if you gave hearing aids away free in the USA, you probably wouldn't come up to the acceptance level that you have in Europe. So it could be that for a small percentage of the people, but something that people have to know is that you can go right now to Walmart.com and you can buy a direct to consumer for $199. You get two of them rechargeable. And that's not new. That's been available from that group in Illinois for 40 years. They were in every Air Flight magazine, right? $199 guaranteed not to rust, bust, collect dust within 30 days, money fully back guaranteed. And, so there's nothing new about direct to consumer, except now it's gotten a lot more expensive. But, for people who can't afford it, I don't know any audiologist who doesn't donate time to charitable work. I personally will staff, anybody wants to pay my transportation to come and staff a free clinic for people at lower socioeconomic groups or kids, I'll do it. Just, we got to schedule it.
So I'm going to get you on record right now. So our Sound of Life, we have committed, we've already given out thousands of hearing aids, but over the last 10 years, we have committed in the next 5 years to give out over 7,500 hearing aids to those in our country.
I'll do it, sure. So, so the only issue, it's licensure issue, because some states where we do this, if you're not licensed, you can't. Sure. So if we know way in advance and I'm not licensed, I can apply for a license,
There you go.
So these things, again, have to be done properly and stuff. And we used to run a free clinic, even when I was director of audiology at St. Louis University. We ran a free clinic in East St. Louis, which is across the river, which is a lower socioeconomic group. And it's actually where Chuck Berry was from. And my residents in ENT and myself and one or two of the audiologists would go. And I think it was about once a month. But every audiologist does that. I don't know any audiologist who doesn't give back. So when there are people who can't afford the services or the products, just like you said, you gave away 7,500 hearing aids.
That's what we're going to, in the next 5 years, that's our commitment.
And people don't have any idea we do this. And it's the same as other professions. There are dentists who certainly staff free clinics. There are doctors without board. I mean, most of us give back. And so, and of course,
that's our core value, right? Our core value. And everybody in this industry says, I want to help people. Nobody says I want to help those who can afford it. I want to help people. So how do we increase access? How do we increase affordability? And then in turn, how do we take some of that profit or some of that revenue and turn it back into a nonprofit organization? We've been doing it for years.
Right. And there's a difference between our charitable works and our professional work. Not to say that the charitable isn't professional, but it's a separate thing.
Yes.
We have to pay the bills, we have to pay the electricity, we have to pay for those audiograms, right? We have to do all that stuff. But I don't know any audiologist, if you said, hey, I'm running a free clinic for people who are indigent or people who are new to the country, who are immigrants without, I don't want to get into politics, but there are people who need help.
Yes.
And, it's not going to be my full-time job ever, but will I volunteer to go help? Absolutely. No doubt.
That's great. I appreciate that. Now, we're already over time because I think you and I could probably do this for another 3 hours, but everybody would fall asleep. What do you think about, because you and I had this email interaction, and I'm not, afraid to bring it up. What do you think about the commercialization of audiology? I mean, what I've been doing, right? I've been in the lab, I've published, my work's been cited over 1,000 times. So I have that, but I also feel like part of our calling, and I say our, is to not just educate each other, but you and I both agreed health literacy is deplorable. Yeah. So getting out the word, I mean, is that an avenue for hearing healthcare providers?
So 2 things on that. Number 1, health literacy and health practice is deplorable here. I don't want to upset anybody, but go to worldhealthorganization.org. You'll see the United States of America is rated 37th in healthcare across the globe. That's important to know. We are not the shining city on the mountain, as far as healthcare. We have people like Keith Darrow. We have people like geniuses and wonderful clinicians, but most people don't have access to them. And it's not because hearing aids are expensive. It's because we have a lot of third-party stuff. 1/3 of all healthcare dollars goes to administrative costs. And so it's not going to Dr. Darrow. It's not going to Dr. Beck. It's not going to the audiologist, the speech language pathologist, the nurses, the physician. So 1/3 of it is taken out by administrative costs. This is a real problem. And then when you have insurance, when you're one of the very lucky people who has insurance, you have to go where your insurance tells you to go. If I have a brain tumor tomorrow, I actually know that some of the best neurosurgeons in America. I may or may not be able to go to them if my insurance allows me or doesn't allow me, right? And this is a bit of an issue because you do have brilliant clinicians around you who you can't access because, you're paying every month for an insurance who is contracting with the least expensive provider. So that's one thing. The commercialization of audiology, I think it's important that we have our national and state organizations who should be working diligently to promote the professionals, much like the American Medical Association does, much like the American Dental Association does. The true factor there, in my mind, it's about cost. When you have hundreds of thousands of members like they do, and each of them kicks in $500 in fees a year, you can do stuff. When you only have 14,000 audiologists in the USA, which is what we have, and only about 12,250 of them work full time, it's hard to raise enough money to have a campaign that would really tell people what an audiologist is and what they do.
The God Hearing campaign.
Yeah. I mean, the got milk thing, actually wasn't really successful. We all know what it is, but it didn't really sell more milk. And as a result, you have almond milk, right?
Exactly.
So, I'm not sure that the dairy farmers really, really appreciated how that went. But, so, I mean, you raised an interesting point, right? This is 2022 and people think of hearing aids as, maybe an over-the-counter or direct-to-consumer product. And, every now and then, maybe those are going to work out just fine. But for the most people who have significant problems, who would seek help, I think they're much better off getting, this is medicine.
Right.
Diagnosis first, treatment second. There's not one physician, there's not one doctor in America who would say that's wrong. That is how we take care of patients. And that gets you to the very best answer, do no harm, right? Hippocrates, but then, diagnosis first. And what you were talking about with sensory neural, it is our trendy diagnosis, but it doesn't tell us everything that Harold Shipnick knew in Chicago, right? And when we take shortcuts, clinical shortcuts, and we do free screenings, we're not really getting to a diagnosis. We're saying hearing loss. And hearing loss, that's a symptom. I mean, if you're lucky, all you have is hearing loss, outer hair cell damage, and we can manage that really, really well. But you could also get that diagnosis and have 85 other things going on because nobody looked deeper. You got to peel the layers off the onion in order to get to the onion.
Well, Doug, I am so appreciative of your time. I believe that there will be thousands of people in our industry, even beyond, who genuinely will get so much knowledge and so much information out of this. I am forever grateful that you took this time. Thank you for being here today.
Thank you for the kind invitation, Keith. It was a joy working with you a few weeks ago, wherever we were. I think we were in Kansas City.
Yes.
And I would look forward to working with you again in the future. I wish
absolutely.
you
now, but what we didn't get personal enough. So in the last 30 seconds, I know you're a musician, so I'm going to stick with that. What's your favorite song?
Any song that my daughters sing in harmony.
Okay. We'll stick with that.
All right. Thanks a lot, Keith.
Thank you so much, Doug. Take care.
All right. See you later. Bye-bye.